Welcome to our second and last video on intracranial hemorrhage. Let's begin. Here is an overview of what we will discuss in this lecture. Let's begin with subarachnoid hemorrhage. We'll take the time to explain definition, risk factors, clinical presentation, diagnosis, and management of subarachnoid hemorrhage. A subarachnoid hemorrhage is defined as bleeding into the subarachnoid space, which is located between the pia mater and the arachnoid mater. This space houses most of the cerebrospinal fluid that bathes the brain. As we stated on the previous slide, a subarachnoid hemorrhage occurs deep to the arachnoid mater and superficial to the pia mater. A subarachnoid hemorrhage is usually caused by either a ruptured intracranial aneurysm, most commonly a Berry aneurysm, or an arteriovenous malformation. Most of the time, the ruptures of Berry aneurysm occur spontaneously, not as a result of head trauma. This is a CT angiography showing a Berry aneurysm. These types of aneurysms usually affect the arteries of the circle of Willis. We can see the aneurysm here. This is an MRI demonstrating an AV malformation that we can see here. There are three main things that increase the risk of developing a subarachnoid hemorrhage, which are smoking, hypertension, and using stimulants such as cocaine and methamphetamine. Most patients who present with a subarachnoid hemorrhage have a severe, sudden headache that doesn't respond to non-steroidal anti-inflammatory drugs. Patients often state that they are having the worst headache of my life. Symptoms of a subarachnoid hemorrhage can also mimic those seen in meningitis. For example, neck stiffness and photophobia are common symptoms that can be present in both meningitis and subarachnoid hemorrhage. Patients may also present with cranial nerve deficits. This happens when the enlarging or ruptured aneurysm compresses a nearby nerve, for example, the oculomotor or optic nerve. Here is an illustration showing the circle of Willis. If the Berry aneurysm involves the posterior communicating artery, neurologic deficits of oculomotor nerve will be present, such as ipsilateral ptosis and dilated pupil. Also, if the aneurysm involves the anterior communicating artery, the optic nerve, or optic chiasm, will be affected, and unilateral vision loss or bitemporal hemianopsia can be present, respectively. When there is suspicion of subarachnoid hemorrhage, the clinician should order a non-contrast head CT. If a hemorrhage is present, it will show up as hyperintensity in the subarachnoid space. A non-contrast head CT demonstrates whether or not a hemorrhage is present, but it does not give any information regarding the vessel that is bleeding. To find out which blood vessel is causing the hemorrhage, the clinician should perform angiography. Another test that can be performed is a lumbar puncture. A lumbar puncture is a very sensitive test, so it is ordered when the CT scan is negative, but the clinician still has a strong suspicion of subarachnoid hemorrhage. If the lumbar puncture reveals xanthochromia, this is a positive test. Xanthochromia is a discoloration of the CSF. We'll take a look at this in a moment. Elevated red blood cell count can be found in CSF analysis as well. Here is a non-contrast CT of the head demonstrating a subarachnoid hemorrhage. Note the hyperintensity within the subarachnoid space as shown here. This is an angiogram demonstrating the vessel that is causing the hemorrhage. Here's an example of xanthochromia. Xanthochromia means there is a yellowing of the CSF. The yellow color is caused by the presence of bilirubin in the CSF. Remember that heme from red blood cells gets converted to bilirubin, which can appear yellow. Treating a subarachnoid hemorrhage should begin with supportive therapy, meaning the clinician should provide airway management, ensure there is adequate breathing, and administer intravenous fluid. Anticoagulation reversal and blood pressure control should be performed. If emergent surgery is indicated, there are two surgical procedures that can be used to stop the bleeding. These are endovascular coiling and microsurgical clipping. One potential complication of a subarachnoid hemorrhage is cerebral vasospasm, which can occur several days after the hemorrhage onset. In cerebral vasospasm, the arteries that supply the brain, usually the vessels that are part of the circle of Willis, narrow and spasm, leading to impaired oxygen delivery and ischemia of brain tissue. Importantly, clinicians can prevent cerebral vasospasm by administering nimodipine in patients who have had a subarachnoid hemorrhage. Let's do a review question. A 35-year-old woman was brought to the emergency department due to severe headache for 2 hours. The headache started suddenly while the patient was cooking. Physical exam reveals neck rigidity and positive Koenig sign. The patient is afebrile. The non-contrast head CT scan is unremarkable. What is the best next step in diagnosing this patient? This young woman presents with sudden onset severe headache for 2 hours. Physical exam reveals neck rigidity and positive Koenig sign, suggesting meningeal irritation. However, the patient is afebrile, making meningitis unlikely. A sudden onset severe headache along with meningeal irritation raises strong suspicion for subarachnoid hemorrhage. The non-contrast head CT scan is unremarkable. If the clinical suspicion of subarachnoid hemorrhage is still high after unremarkable non-contrast head CT, one should perform lumbar puncture. Lumbar puncture usually shows increased red blood cell count due to hemorrhage and xanthochromia due to hemoglobin breakdown into bilirubin. Now we'll move on to discuss intraparenchymal hemorrhage. We'll discuss definition, etiology, pathophysiology, clinical presentation, diagnosis, and management of intraparenchymal hemorrhage. Intraparenchymal hemorrhage is also known as an intracerebral hemorrhage. It is defined as bleeding within the brain parenchyma due to rupture of blood vessels in the brain. Here's an illustration of intraparenchymal or intracerebral hemorrhage showing the accumulation of blood within the brain parenchyma. Let's discuss etiology. Chronic hypertension is the most common cause of spontaneous intraparenchymal hemorrhage. However, cerebral amyloid angiopathy is the most common cause in elderly patients who are more than 60 years of age. And arteriovenous malformations is the most common cause in children. Other causes include coagulopathies such as hemophilia and the use of anticoagulation medications, herpes simplex virus encephalitis, tumors, the use of certain drugs such as cocaine and amphetamine, and lastly, head trauma. We will discuss the underlying pathophysiology of some of the causes we just mentioned. So, chronic hypertension causes hypertrophy of the tunica media of the small lenticulostriate arteries in the brain and formation of lipofibrous deposits in the walls of these vessels, a process referred to as lipohyalinosis. Lipohyalinosis reduces the integrity of blood vessels and leads to developing tiny aneurysms called Charcot-Bouchard aneurysms, which eventually rupture. Rupture of these aneurysms cause lacunar strokes which affect the basal ganglia, including the putamen and thalamus. Another condition that can lead to intraparenchymal hemorrhage is cerebral amyloid angiopathy. It is caused by amyloid deposition in the walls of blood vessels in the brain. This weakens them and increases the chances of vessel rupture. Rupture will cause a hemorrhage within one of the cerebral hemispheres. Clinicians sometimes refer to this as a spontaneous lobar hemorrhage, which is non-traumatic. Arteriovenous malformations can also rupture and lead to intraparenchymal hemorrhage. In AV malformation, the arteries directly anastomose with the veins as they bypass the capillary beds. Bypassing the capillary beds causes the AV malformation to become a high-pressure system, which can lead to aneurysms and spontaneous bleeding. Let's discuss the clinical features of intraparenchymal hemorrhage. The symptoms have gradual onset, progressing over minutes to hours. Patients often have one or more neurologic deficits, which can get worse over time due to the expanding hematoma. The type of neurologic deficits depends on which part of the brain is affected. The expansion of the hematoma can also lead to high intracranial pressure, but this is usually a late finding. Features of elevated ICP may include nausea, bradycardia, and impaired consciousness. Bleeding that affects the putamen can cause contralateral hemiparesis. It also causes a gaze palsy, where the eyes deviate to the side of the lesion. If the bleeding affects the thalamus, patient will present with a different set of symptoms. Since the thalamus receives sensory input, the hemorrhage will cause contralateral hemisensory loss. It can also cause a gaze palsy, where the eyes deviate to the opposite side of the lesion or hemorrhage. An intraparenchymal hemorrhage is diagnosed with non-contrast head CT. The bleeding will show up as a hyperdense area within the brain parenchyma. If the bleeding is chronic, it can appear hypodense rather than hyperdense. This is a CT of an intracerebral hemorrhage affecting one of the cerebral hemispheres. Note that the hemorrhage is unilateral and it is within the parenchyma of the brain. Most cases of intraparenchymal hemorrhage can be managed conservatively with airway management, cardiovascular support, anticoagulation reversal if the patient takes anticoagulants, and blood pressure control. A surgical hematoma evacuation with or without a decompressive craniotomy is considered if there are some indications. For example, if there are signs of brain herniation or deteriorating neurologic deficits. Here's an illustration showing all the types of intracranial hemorrhage that we discussed. Please pause the video and take a moment to consider this image. Let's end our lecture with a board-style question. A 65-year-old man is brought to the emergency department reporting severe headache for 4 hours. Past medical history is significant for chronic alcoholism and uncontrolled hypertension. His vital signs include a temperature of 37 degrees Celsius, a blood pressure of 190/130, a heart rate of 89, and respiratory rate of 14. Physical exam reveals right-sided hemiparesis and left-sided deviation of both eyes. Non-contrast head CT scan shows expanding hyperdense mass in the left-sided brain parenchyma. Which of the following structures is most likely affected in this patient? A. Thalamus, B. Putamen, C. Cerebellum, D. Septum pellucidum. This man with chronic alcoholism and uncontrolled hypertension presents with severe headache for 4 hours. His vital signs are significant for malignant hypertension of 190/130, blood pressure of more than 180/120, along with signs of end organ damage, like in this patient, is called the hypertensive emergency. Physical exam reveals right-sided hemiparesis and left-sided deviation of both eyes. Non-contrast head CT scan shows expanding hyperdense mass in the left-sided brain parenchyma. All these findings suggest the diagnosis of intraparenchymal hemorrhage due to malignant hypertension. The most likely site of intraparenchymal hemorrhage in this patient is putamen. This is because putamenal hemorrhage is associated with contralateral hemiparesis and ipsilateral deviation of both eyes. Therefore, the correct answer is option B. Here is a slide reminding us of the clinical features of putaminal and thalamic hemorrhages. Pause the video and take a moment to consider this slide once more. Let's discuss why other options are incorrect. Option A is incorrect because thalamic hemorrhage is associated with contralateral hemisensory loss and contralateral deviation of both eyes. Option C is incorrect because cerebellar hemorrhage is associated with cerebellar signs like ataxia, dysdiadochokinesia, and dysmetria, which are absent in this patient. Finally, option D is incorrect because septum pellucidum is an ultra-thin membrane separating the lateral ventricles from each other. It is typically not involved in the intraparenchymal hemorrhage. And that concludes our lecture on intracranial hemorrhage.